Panel discussion on what you do mean by quality. Dear friend, Dr. Nisha Agarwal. Dr. Nisha is a scientific diet and embryology in the Vasundhara Fertility Center Private Limited, Nagpur. He is also lab director in Icon Hospital, Nagpur, India. 19 years of experience.
The audio is not clear. The audio is not clear.
Please speak loudly. Speak loudly.
Hello.
Yeah.
Sarika, not audible, not audible.
Sarika, switch on your mic.
I think there is some problem with that network.
There
Maybe
might be
Rahul, you can take over.
I think it's okay. We can begin.
We can, yeah, I think we'll begin. It's okay.
And there is a lot of echo.
Yeah.
Nishad, echo is coming from your side, I think.
There are need to switch off someone. Extra mic is on, I think.
Is there an echo now?
Yeah.
Just a moment. I don't think.
Any extra add-on speaker is there from at your side, Nishad?
Just a moment.
Dr. Akash is SC certified embryologist and topper in X-ray clinical embryology in 2019. He is actively involved in academic and co-authored a book.
I
He
think
is a member
I
of
think
National.
Tarika will go on to the directly to presentations if you don't mind. I think we are getting a bit delayed.
Okay. Dr.
Sorry
Let's
for
begin
cutting
with-
it. Yeah.
Over to you.
All right then. Just a moment. I'm sharing my screen here. Wonderful, wonderful. Okay. Right. So let us begin with our today's panel discussion, and that is on what do you mean by quality in IVF technology, results, and patient satisfaction. I hope I'm audible.
Yes.
Yes. Okay. So let me begin with our panels today. We have Dr. Saili Kandari, who's a very dear friend of mine. She has done her MSc PhD in reproductive biology from USA, Chicago, and she's got certification in clinical embryology from Cleveland. She is affiliated to Research Scholar Ronan Institute and the scientific officer of Cell Shore Biotech and Research Center. And she is director for reprogenics and is on the advisory panel on many other companies. So welcome, Saili, here. I hope you are here and I'm audible to you too.
Yeah. Hello.
Wonderful. Yeah, lovely to have you. The next speaker is another good friend of mine. We have Gaurav Kant, senior embryologist at Akanksha IVF Center, first Indian embryologist to be certified by both prestigious international society, that is the ASRM and the ESHRE, senior clinical embryology and clinical embryologist exam. Also certified by the IFS and Global Fertility Academy. He has 11 international presentations and is interest blastocyst biopsy and cryopreservation training from Barcelona. Hi Gaurav, how are you? I hope Gaurav is there. Then we have a great exponent with us. We have Dr. Karsi Avri. I think this person does not require any introduction. His name is enough. He's got a lot of publication. He's a wonderful teacher, a voracious speaker, very articulate, and we can learn a lot of things. I think that is the best introduction I can do for him because everybody knows him and he's a wonderful person. Welcome, sir. Then we have Pranay Ghosh, another good friend of mine. He is a gynecologist and an embryologist. So we've got a mixed bag here. He's done his diploma in reproductive medicine from Kiel, specialist training in reproductive medicine from Singapore, and ESHRE certified embryologist. His special interest is reproductive immunology, oocyte embryology, biology, and optimized strategies for elective single embryo transfer. So hi, Pranay, I hope you're there. Wonderful to have you with us. Then we have Dr. Vandana Hegde. We have another clinician with us. So welcome, ma'am, here. She has been awarded for standing first in her MBBS. She is an OBGYN and has done her diploma in reproductive medicine and embryology from Kiel. She is also a member of various societies, national and international, and awarded first prize in presentation at UVA Foxy in 2005. She's been in the field since 2007 and has 4 branches. And let us welcome Dr. Vandana Hegde here. I hope you're there, ma'am.
Yeah, I'm here. Thank you.
Lovely, wonderful. Then we have Dr. Paresh Makwana, who's another good friend of mine. He's expert in biopsies, blastocyst biopsies done more than 4,500. That is wonderful. Also, oocyte and blastocyst vitrification, in vitro maturation. He's also the executive member of the ACE and other societies as well. So, Paresh, welcome to you. And I think let's begin with our panel, and I will not hold you anymore. And Akash, it's all yours from here.
Yeah. Thank you, Nishad. So firstly, I'd like to welcome all our panelists. We have a lovely set of panelists over here, trained abroad, a teacher with us, quite good clinicians with us, and a couple of very good friends of mine. So I welcome you all to this panel. And we have to discuss this panel with regards to the quality. We all know that IVF is a modern art. It's an art in ART. It's a scientific field which has some very robust protocols to be followed, you know. And despite of well-established robust protocols, we can say the results tend to be variable at the least. So what do we do to minimize this variability? How do we control this variability? And this is dependent to a large extent on the quality. How do we assess quality for this? So with this background, let us start with a questionnaire on this. And the first question would be, when we see ART as a modern science, and whenever we say modern, we tend to associate lots of technologies and gadgets with it. So whenever we are associating these gadgets and technologies, how do you decide when a ART lab is established, it's a good quality lab? So what do you mean by a good quality lab when it is newly established? Maybe Saili can start.
Thank you, Dr. Akash. Thank you for the very interesting question to begin with, that what do you consider a good quality ART lab? So to begin with, for a good quality ART lab to be fundamentally established is what KPIs have we really set down in the laboratory. So before we even start in the laboratory, what kind of infrastructure there is in the laboratory in terms of what is the workflow, man flow management of the incubators from the laminar flow, and what kind of separations have been created when you have created the laboratory. So for example, if you have the OT and the embryology laboratory connected to each other, what kind of air quality management you have in both? Is it separate? Is it same? And what kind of, do you have a positive pressure module or not? These being the basics, whether you have hypoxic culture in the laboratory. So these might be some of the very basic things, whether you have a backup incubator in the laboratory and whether you have a sufficient workspace to manage the number of cycles you are expecting from the lab. For up to 150 cycles, maybe 1 LF would be sufficient, but above and over that, do you have made provisions to increase the required equipments in the laboratory? So that would be where I would start with.
Okay. And what would be your take with respect to the latest technologies? Like you had said about the basic technologies. So what about TLI, time-lapse imaging or something like that, which obviously everybody would want to, but what would be your take on it?
So personally being there in multiple laboratories for setting up time-lapse, what I could say is mostly time-lapse is something that is a new technology that has to be set up in a current technology most of the time, because it is the centers that are already doing conventional culture successfully that want time-lapse in their laboratory. So the workflow management and the change of standard operating protocols is the first thing that happens when a time-lapse comes in. The fact that it has quite a big bench space matters, and also the fact that how your incubators are aligned near and around the time-lapse, that matters a lot. The training of the staff, especially the people who are going to work, the embryologists who are going to work on specifically on time-lapse and annotation. The fact that you need a newer computer space, you need almost 4 to 5 foot of this computer space to make sure that you're annotating them real time. So whenever there's new technology in, definitely the infra, the workflow, everything changes, and you need to have an experienced team to sort of figure out how to safely incorporate any workflow changes and new technology in the lab, especially like time-lapse.
Right, wonderful. Can we have another panelist here? Maybe they can add some extra points here regarding the latest technology. Maybe Gaurav, are you there? Is Gaurav there? All right. Okay, then maybe Pranay, can you answer this? Maybe what is your take? I mean, with the latest benchmarks, do you consider artificial intelligence as a part of this as we are making new labs?
Very difficult to answer because, it is the future. But once you decided to set up a new lab, I think it is very important to get comfortable in your skin with the traditional workflow first before you adopt onto the new technology. And I think it is a good idea to start with the basic minimal, which I say the term as the essential equipment. So semi-essential and experimental add-ons can wait for a while. So if there's a lot of adaptability that you need to be conscious of when you're adopting to a time. You're just doing an example of a time-lapse, but it can be a spindle imaging, it can be a laser, it can be any other new add-on. So first of all, you need to do your homework. That are you a lab which has an in-house embryologist? Okay, that's one question. Are you somebody who's going to be dependent on a freelancing embryologist? What are his preferences? Is he doing sequential culture? Is he doing single-step culture? Are you even in your mind, are you even prepared for the shift from a cleavage sequential yes, to a single sepsis. So in there are a lot of boxes that need to be checked before you go on to invest into something like a time lapse, because it's not an end solution to your problems. It's not going to increase your live birth rates. It may decrease your miscarriage rates. It may help you score the embryos in a better manner to achieve a better time to pregnancy. But I think as a setup that is investing into infrastructure, as a new IVF lab, you need to be making sure that you have ample essential infrastructure. Like you need to have a box and a bench top. You need to have two set aspiration pumps. You need to have a 4x2 or a 6x2 before you go on to think of a time lapse or a spindle imaging or a laser. So double up your essentials before you before you invest in your semi-essentials and experimentals.
Agreed.
That's a very good point, like
Absolutely
what he has
agreed.
stressed. Like you have
Right.
to
So-
first go to your basics, get your basics right. And it might look all fancy over there, but with great new technologies comes great responsibilities also. You should be ready to adapt and use them. So that's a very good point over there.
Yeah.
Any
In
other
addition-
panelists would like add any
Yeah.
addition?
Yeah. In
Nisha.
addition, I would like to ask.
There is
Yeah.
something that I think would be of interest, especially for somebody who's planning a new laboratory. And this is something from personal experience, may or may not be everybody's experience in the panel. When we had set up one laboratory that was doing 100%, so they wanted to be the first 100% hypoxic laboratory. They wanted to have only a low oxygen in their laboratory, which was a worthy aim, considering they wanted to also incubate their media in box incubators which had hypoxic culture. But the problem that we faced in the planning phase itself was that the nitrogen cylinders were not available in that area. And we told them that at that particular point of time, we did not have gas mixers. And the only solution was to put a separate nitrogen cylinder. So we told them to scratch their plan at that particular point of time. But now that even with gas mixers, if you do not have the sufficient consumables like the gas supply, then you should really make sure that your infrastructure is when you're in the planning phase, you should know what is available in your local area so that you design a lab that actually gives results. And like you said, it doesn't just have fancy stuff. It basically is something that's workable, and it's giving you hitting all the right KPIs like excellent clinical pregnancy rates and live birth rates. So you have to make sure that you work with what you've got. And if you only have triple gas available, then you need to make sure that you're buying incubators like that. So just something to share from experience.
Yeah. So we need to get the basics first set. Yeah, Paresh, please go ahead.
Yeah, I'm agree with her that we have some basic setup, but when we are talking about the new gadgets and latest benchmarks, actually we have to do our own research. Like now I'm something talking different, that we are talking about some closed system which maintain the CO2, O2 and temperature. We know it's means just add-on, okay, but I feel that whenever you are getting some add-on and you are moving towards the physiology, it's good. But you need some research only. And when we are moving toward the physiology, we are giving lesser stress to our gametes. And that is very much important, actually.
Yeah.
Anyone would like to contradict the take? Like, why not?
Dr. Kursi, would you like to have a take at this, please?
Yes. Good evening to all of you. One thing which confuses me is whenever results go down, why do we always jump to the instruments, the latest technology? It was not there, it was there. Why don't we first of all target the quality gametes used? Has anybody done a QA/QC on that? You may be having the best of the best labs and the ultimate, because there is no end of gadgets coming in and day out. Of course, the prices reaching the stratosphere. And they are not like a Pandora's miracle box that they will churn in the best of the best results from the worst of the worst gametes. So before us jumping to the conclusion and adhering to all the KIPs and the guidelines and the consensus and blah, 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 definitely we should first make it a point whether it is applicable to us, whether it is worthwhile in our system, whether it can be possibly feasible for any single lab owner to buy and purchase all that. It is indeed essential, but not imperative. There have been successful results in the most simple labs, but what I would target is the quality equipments which you buy for the purpose, for that purpose, should be excellent. There should be a proper trained mindset behind that gadget. There should be no dearth of knowledge. There should be professional dexterity. Till that time, these gadgets, artificial intelligence, your multiple incubators, your supra ultra HEPA purified air of even 1 ppm per million. Okay, this is not going to be of any use, albeit it is definitely a part and parcel of a lovely buffet table which is spread before you, right? But first of all, be sure about the ingredients what you are cooking in. Okay, these gadgets will definitely provide you peripheral and this what you call it as a balancing act or a cloak of protection. But remember, the couple who has been running from pillar to post with infertility, the phenomena which is shunned in our society, has definitely no other option but to go to the place, and there you cannot expect, will this lab be good? When you are offering the services as meticulous, as ethical, like embryology, definitely there should not be any questions about the quality, about the QA/QC, or about the performance indications. But at the same time, let us not jump to it. If I don't have time lapse, oh, finish, I am gone. You know, technologies are going to come, whether they are evidence-based, whether they actually help into it. Because whatever technologies are there, we are dealing with a human cell, and 99.9% we are dealing is just the morphological aspect in any cell, oocyte, embryo, or sperm. Except certain things in DNA, like DNA fragmentation of the sperm, there is a little window of an insight into the cellular structure. Till that time, it is all that glitters is gold. That's the approach. Carry on.
All right, wonderful. So we can say that the secret ingredient here is that get the embryologist on board before building your lab, so that that person will be able to help you and guide you to get the basic instruments and equipments and benchmarks, and so that you can have a good lab in the beginning, and then you can develop it slowly and steadily. Am I right?
Yes.
All right. So should we move to the next question now? Yeah. So what would you do? Would you like to add as quality for clinical aspects of the ART? Would ask Dr. Hegde to answer this, please. So what would you like to add as quality when it comes to the clinical aspect? Now we've done the embryology part. Let us move to the clinicians part.
For us, with respect to quality, no matter whatever be, finally our goal is to get a good success rate. So finally, what drives our success rate is we know the number of oocytes. So our stimulation protocols, which I would suggest, and a part of the technology that you are talking with respect to embryology lab, on the clinical side, I would like to add the most important one is the selection of your ultrasound machine. So today with the 3D ultrasound and the Doppler coming, it is becoming very important to select a good ultrasound machine, which can help you monitor the stimulation better. And from the clinical side, I think we drive the patients for the selection of the protocols. So I think as you know, that counseling is a very important part with respect to the use of the technology. So we as clinicians, we need to counsel the patient, telling what is important and what may not be that important for their success rates. So these are important in selection of the thing.
All right. Okay.
Pranay,
would you like to add here?
Yeah, so when you talk about quality, I think at some point of time, somebody in this panel would mention that we have to be proactive instead of being reactive. And just troubleshooting a hypothetical situation that you're not getting good results, whatever, not getting good embryos, not getting implantation or pregnancy. And then grossly, how do you troubleshoot? You troubleshoot, the embryologist troubleshoots his or her culture system, and the clinician troubleshoots her gonadotropins, right? So in my mind, when you're talking about clinical aspects of ART, apart from the infrastructure setup and the ultrasound and all, you need to be very vigilant of being as anal about your gonadotropins as we are about our culture system and the culture media. And I think another point that I need to make about the quality in the clinical aspects of ART is, thankfully now STA has also given the reference indicators, at least for some of the parameters that the clinician can gauge and measure at their end like we could with the Vienna consensus. So we have come up with a new consensus, which is called probably the Marlborough consensus, or just give me the Maribor consensus. So this is a new consensus which has come up, and it has probably chalked out some of the reference indicators that you could look up to and see that your clinic and you as a clinician are performing adequately well in terms of being an OHSS free clinic, in terms of retrieving expected number of oocytes with these many follicles visualized, and so on and so forth. But I think as I went through this Maribor consensus, I thought that it was very brief, and they need to add on a lot more reference clinical parameters to gauge the clinical work objectively. So yeah.
All right. Okay. I would like to know, like, if anybody is interested in talking about counseling, how important it is, how to control the flow of patient, because at the end of the day, it is the clinician who is getting the patients, and only then you have a workload, and then only you are able to do enough cases to have some results. So how important is all these factors here? Please, if anybody can answer this.
Could I take that?
Yeah, sure. Please go ahead.
Okay. All right. So in terms of counseling, just trying to evaluate a hypothetical situation. So, for example, you have a patient A that is coming in and talking about they need an IVF cycle. They've already done multiple IUIs, and they're going to start an IVF cycle in the next week or so when she gets her periods, or maybe she has come on day 2 of her periods, and you're counseling her to immediately start her cycle, or as and when is clinically possible. The first counseling session is quite long generally for patients, and they may or may not understand all the concepts of IVF. So we really appreciate when we have clinicians who are in constant communication with the patient. So, for example, if the patient is coming in on day 5 of the cycle, and they have an idea of how many follicles have been recruited, and on day 8 they have an even better idea of how many follicles they would probably get on the day of the retrieval. That is probably the time they could talk to the patient regarding whether they just want to do day 3 transfer or a blastocyst transfer, and start talking to the patient about vitrification, dependent on what her current situation is. So that is something I think really makes the job easier for the embryology director, because or the laboratory, because then we know in advance what we are planning for this patient. Well, there are changes at the last moment dependent on what you get at retrieval, but sometimes knowing in advance what to do with the patient, it's just easier to make sure that we have enough media in the laboratory for that particular case. We're making sure we are scheduling in these patients for the right things, scheduling in them in for single blastocyst transfer or single embryo transfer. All this flows in from how the clinician communicates to us. And we don't work in silos, we work as a team. So this is from my side. Yeah.
One important part of counseling I would like to add, the new aspect that we use is the ART calculator. So this helps even the embryologist and the clinician in counseling patients, especially when you deal with their first failure. Because IVF, we all know that it's a 40-50% success rate. So counseling is important to motivate the patient to try more number of cycles. That's where counseling helps. And the recent ART calculator actually has very good guidelines on counseling, basically, depending on the gamete source, the female age, and the number of cycles required to achieve the success rate. If you give this counseling in the initial part, the patient is ready to accept 2 to 3 IVFs for achieving their success. So this, I think, is the most important thing as a clinician and embryologist, explaining them the number of oocytes required to get 1 euploid blast. That should be the driving counseling throughout. The whole team should counsel on the same lines.
So, Dr. Hegde, this ART calculator is the Poseidon calculator, or is it something else that you use?
It is with the Poseidon criteria. Yeah, it is with the Poseidon criteria. We use that. Poseidon is more of a patient, it's for basically the lower responders and the suboptimal responders, but ART calculator can be used for anybody. So it helps the patients. It will make them understand actually what is because in India, everybody expects a magic success rate, but this actually guides them. It's available online. So you just fit all the parameters into that, and they get to see their own success rate.
Yeah.
All right. Okay. So shall we move on to the next question now? Yeah, Akash.
Yeah. So we have seen that they were the abstract things. Quality is much more of an abstract thing. We tend to quantify everything. As human beings, you always want to have indicators where we tend to put a mark 30%, 50%, 70%, because that's how we can compare ourselves. So when we go in for this quantification, so what are the parameters which we would consider as important for quality in terms of the lab? Other than just the live birth rate, which obviously is the most important parameter which would be over here. Maybe Paresh can take it, or Pranay, you can go ahead. Sure.
Yeah, important parameter other than live birth rate are actually your fertilization rate, your your blastocyst conversion rate, and your cryosurvival rate. That is what I believe actually.
Okay, so FERT rate, cryosurvival rate, they would be the most important. Anyone would have any other three important ones? Pranay, if you...
Yeah, I think Paresh is right when he's talking about the embryological parameters, but as a clinic, as a whole unit, apart from the cumulative live birth rate, I think it's not even the live birth rate, it's the cumulative live birth rate, which is the most important. The other 2-3 key parameters that would be most important for me, not just the embryology KPIs, would be the patient conceiving with the cell gametes, the time to pregnancy, and how expensive is the treatment for the patient. And one more factor would be the safety of the mother during the course of the journey while she's conceived, and the neonatal outcome. So I think if we combine all of this, I think it would be the most succinct statement that I can make is that a patient who goes on to conceive a singleton with her own embryos in the shortest time, in the cheapest possible manner, is what we are.
Yeah, I agree with Pranay that it's very important to keep the costs very, very tight for the patient, for the sake of the patient, because we will be able to improve access to care because of that. So one of the parameters that I really think clinicians appreciate and like from the laboratory is the percentage of M2s that you get from a cohort of patient oocytes. And these are, if these are above a certain percentage, for example, 90%, I think that really benchmarks what you should expect from a cohort. And if it's dropping down, then either there is a problem with timing, or there's maybe a change in timing of the SCG trigger. Maybe there is some other change that has happened in the whole IVF program. That's reflecting. So that is also an additional thing. And also the day 3 cleavage rate. So the 2PN to day 3 cleavage rate is something I like to personally monitor, because that kind of tells me the number of 2PNs that are progressing.
Yeah.
All right.
And,
it's a good point. Yeah.
When I'm talking about the fertilization and blastocyst rate, why it is so much necessary, because what happened when you are doing regular culture, and definitely you are checking your quality control around a regular interval. But when there is a sudden drop in the blastocyst conversion rate or sudden drop in fertilization rate in terms of without there is a change in the gamete quality, okay, because it is not, as Dr. Casey said, it is not like that you are not going to get the blastocyst just because of the quality. It is also because of the gametes. But if you are continuously observing there is a problem in the gamete, the blastocyst conversion rate or fertilization rate or day 3 embryo formation rate, then definitely you can consider there is a certain change in the quality of the lab, and you can improve or you can just go through your SOPs and actually you come to know what are the changes you can do there.
Okay. Sally, coming to your point of M2 rates, I would like to say, like, what would you say for clinics who nowadays even aspirate the smaller follicles? So in terms of the M2 rate.
Okay, so I'll repeat the question. You just want me to add a comment on what happens when you aspirate the smaller follicles?
Yes, so the M2 rates would go down, right?
Yeah, that is for sure. But there is also, Dr. Akash, there is also an additional, there's a study that says that you can get a mature M2 follicle, M2 oocyte from even a follicle that's as small as 12 mm. 12 mm. So anything less than 12 mm, I guess you're just adding blood to the follicular fluid, and you're probably not gonna get anything viable. So for example, in PCO, if you keep puncturing these smaller follicles, which you generally see these necklace-like pattern in these patients, if you keep puncturing that, you're just gonna get more GVs or even nothing, and just additional blood in the aspirate. So yeah, that's a good point. That's something that should discourage clinicians from going for follicles less than 12 mm or less than 10 mm.
But there's one more factor that we have to talk about is the cytoplasmic maturity. That does not happen. And I think rather than me, I think Dr. Kersey wanted to say something.
Yes, as far as these parameters are concerned, I would like to draw a fence between the two sides, the clinician side and the embryologist side. The parameter which will be this, how many follicles we see on the scan starting from day 5 of the stimulation, right? How much they grow, because 5 to 10 is the growth phase, 0 to 5 is the recruitment phase. So our basic observation starts from that. Once they get it, how much are we trying to retrieve? So that's the retrieval rate. So the retrieval rate in proportion to the one seen on the sonography is the other side of the fence. But once they are retrieved, how much is the maturity rate or how much is the M2's rate? Now M2 definitely in an IVF will come to know on day 1. In case of ICSI post denudation will come to know on day 0. Then subsequently we find how good is the fertilization rate. Okay, then the cleavage rate, then the embryo culmination rate, and ultimately from that cohort, how much is the blast culmination rate? And believe me, the numbers don't stand fixed for all criteria. They are always fluctuating. So this is where the basics are, that we have to draw a parameter consensus right from the time the gametes are recruited in the body itself, because ultimately it's those recruited gametes which we are going to work with. So that's why I said that even a large cohort doesn't mean something excellent, or even a large retrieval of the eggs doesn't mean that we are thumping our backs. It all depends upon the timing of HCG, the nature of HCG, the egg collection time, the method in which the OPU is collected, the cleanliness of the aspirate fluid, the incorporation of the blood, the time during scanning. The list is endless. So this ultimately is the basic benchmarks of any embryologist, in which we don't need any high-end gadgetry. It is just the expertise, knowledge, the dexterity, and the clean working condition. Bingo, that's it.
Right, the basic sets what we require. That's the point to be taken, that it's a basic, and it has to be worked from both the ends. It is where the communication plays a very important role. Okay, Nishad.
Could I make a last point? Could I make a last point before you move on?
Yes.
So there was an excellent paper in fertility and not fertility, in human reproduction, talking about how implantation rates are very misleading and how these should be scrapped from the KPI rates. The KPIs of most laboratories, because implantation rates are very much dependent on how many embryos you are transferring for embryo transfer. So this is something up for debate, but we don't monitor implantation rates anymore. The simple reason being that implantation rates can really change if you're putting 2 embryos versus if you're putting 1 blastocyst. And it's just easier to look at clinical pregnancy rates. So you just have to wait probably 6 more weeks to get that data. So that's something I wanted to add.
Someone is monitoring implantation rates from the panel? Anyone? Just a quick yes or no. Just a quick yes or no.
No. I just have a comment to say that if you do a SEP, it's not a lot of data to handle. Your pregnancy rates are your implantation rates.
Okay.
So move towards.
So if you're doing
move on to the next.
If you're doing SCT, you don't need to monitor implantation rate anymore, because your CPRs are your implantation rate. Is the way I would spin it. Is the way I would spin it. It eventually being that it's too much dependent on the number of blastocysts, and unfortunately, and not unfortunately, the reality is, the real scenario in India is that most centers still do transfer more than 1 embryo, and the ones that are doing only 1, kudos to you. Please continue your practice. We love you. But for the rest, let's just leave the implantation rate a little bit aside for the timing.
All right. Okay. Thanks. All right. Let's move to the next question. Yeah. So what other than KPIs are the parameters which you recognize are important for quality? So I'll start with Dr. Kersey here.
Well, other than KPIs, now KPI is a long list. I think it incorporates
Yes.
everything under the sun. Unless
Right.
and until we really go out of the way to find out that this might be the cause. Like years ago, nobody would have thought that air quality is important. Or maybe a little incident, sunlight into the room thanks to the UV is important. Or maybe the VOCs are important. Now, slowly, as we started getting the negativities in the result, in spite of excellent gametes and excellent culture condition with a brilliant embryologist monitored in the scenario, we tried to explore other areas. Yahan tak ki we have even went on to that quality of the packing of the disposables, how they are. Okay?
Right.
The nature of the disposables, the coating of the biological layer in the disposables. So this is the list is endless. At the same time, we are also exploring the other KPIs as far as the injections and their efficacy, their bioavailability, their half-life in the period, and the most important is the patient's history into which they are taken into. Many a times we don't take the patient's history, the patient's problems. We don't rectify the problems before recruiting them for the procedure. And then we go merringly hunting around the bush where the problem lies as such. So the KPIs today formed are booklets, are volumes. If you were to follow each and every one of them meticulously, I think the debates are never going to end. So I would find that we have to draw somewhere a death line. Beyond this, I'm going to stop. Otherwise, it's going to be me just trying to blind a black cat in a dark room. Simple as that.
Right. All right. I have a question for Dr. Paresh. I think the whole point of this is that as an embryologist, we are not only, left with the lab itself. So can you elaborate further more on the points that you have to take care as an embryologist when it comes to quality improvement in your lab or in your IVF center?
Definitely, I will go with the staffing, and actually I will go with that SOPs. Here the SOP is very much important actually. When in the nowadays actually you have a lot many junior embryologists, you have trainee, so you have your proper SOPs. So your SOP is too much important because what happens when there is anything goes wrong in your protocol or in your procedure, you should know at least where is the lacuna. Because what happens if you don't have a proper SOP, then you have to find out actually which level it happens. So for me, the SOP is very much important, and the staffing is very much important. The main thing is the positive environment in your lab. If there is a gap between the communication, there is a communication gap between two embryologists or embryologist and clinician, it is going to affect your quality.
All right, agreed. Pranay, would you like to add something here?
I think the task is cut out for labs like Paresh is heading. For me, it's kind of a little easy I'm heading, and I am the one who 4 different embryologists. But yes, I think objectively speaking, now everything comes down to how you performing on your paper. And because I know for a fact that some of the embryologists have been told not to be performing one particular procedure because they, despite months of retraining, have not performed adequately. So again, to re-emphasize with regards to quality, always be proactive. Never try to just be never be taken aback by a situation which you are never prepared for. So another point which I would like to which was previously discussed in the question was counseling. So we talked adequately about clinical counseling, but I think the embryologist should take some opportunity at some point of time before the pickup to have a word with the couple with regards to getting the consent signed in terms of the ICMR designed consents, which says that no assurance of oocytes being retrieved, no assurance of if oocytes are being retrieved, they're immature, no assurance of fertilization, no assurance of blastocyst, implantation, pregnancy being, and also that you don't cut a sorry figure at the end of the day once the cycle fails. So be prepared for it adequately well in advance. And I think the trigger day would be an adequate opportunity for the embryologist to be talking to the couple. I think I can talk about quality all day long. What do you specifically want me to talk about?
That's a good point that you made. Yeah, Dr. Kersey was saying something here.
Yeah, as far as counseling is concerned, I would like to break up counseling into two parts. Counseling number one, or the first initial phase of counseling, is when the patient approaches an infertility specialist for treatment. That time we counsel her to the best that this is not that 100% guarantee success wala center, which many of us valiantly advertise nowadays. There are many pros and cons, ifs and buts. Whether the ART procedure is actually needed for them or not. Believe me, when you counsel well, 3 out of 10 patients just walk out because you are telling them the truth, and the sad part is they are not ready to digest the truth because they have been fed so misnomer and the other nonsense rubbish from the other people around. So that is the thing in counseling. Once they set their mindset in a particular properly set trend, the trend is set, they are focused, they come to the clinic with a clear intention, clear mindset. And the secondary counsel would be that once the procedure has started, maybe the mid-procedure counseling, sometimes the patient goes into a trauma, oh my gosh, only 5 oocytes, I was assured of something like 12. How many you will transfer? How many you will freeze? So this also creates a severe psychosomatic stress on the patient. So what we should suggest, or we should tell is, whether you counsel, never make it a point that you counsel always to your advantage. Make it a point that you always tell the patient the pros and cons. Otherwise, the most friendliest patient will literally draw daggers with you once the result comes negative. So this is very important. These are certain points many a times we miss. So we as an embryologist should also be given an ample opportunity to mingle with the patients, tell them the true scenario which exists in the lab, because if we don't mingle and don't tell, the patients take a very negative message. Okay, what hanky-panky goes on, nobody comes and reports to us till the very last day, you are negative, you are positive, and that's it. So this parameter has to be taken into consideration, because remember, what the patient needs is a sense of assurance. That's very important. The patient shouldn't feel that they are cheated. The patient shouldn't feel that their work was ignored. Leave aside, the patient is not going to see whether you are following the KIPs or SOPs or equipments or the highest grade equipment. They say, I entered, came to you with a true faith, confidence in you. You never contacted me. Just like it was said that when the daily sonographies are done, it is a very duty of a gynecologist to be present on every day to see if the patient is comfortable. Many a times patients complain. Nobody was there. The doctor didn't even attend to me. Carry on.
It is about informing the patient, having a total information
patient
to
awareness,
the patient,
transparency.
Awareness.
There has to be complete transparency. Right. Let's place ourselves in the patient's shoes and think what they expect, because they are in the severe financial, psychological, and physical trauma.
Emotional trauma. Yes. Very well said, sir.
And also today, legally, I think we need to document every counseling.
Yes, absolutely.
You should
because
be
nowadays,
nowadays
it will so happen that embryology will be more of documentation rather than the actual procedures.
Whenever you counsel anything, it's
Kersey,
better to have it on.
Also very important.
It's
also so very important to document.
Yes,
and,
you have to document
it is one of the main
details. Absolutely.
Yes.
Now you won't believe there was a case where the home semen collected sample was substituted for somebody else's sample. So there also we had to prepare a document and say that we blah, blah, blah from this place had given the sample home collected at blah, blah, blah center for the blah, blah, blah procedure, signed by both the husband and the wife in front of each other. So these are fine things sometimes we miss. We assume or we presume that everybody is honest, but no, it's not so. Because the infertility trauma is so severe and dangerous and traumatic that patients will go all out to see that their goal is achieved. So that's why I always say for an infertility patient, never take their yes, which is said over the counter immediately. Many a times they go home and change their viewpoints. You may find a phone call later on in the day, no doctor, we have decided against it. You got my point. Where everything
it's a common thing.
Yes,
it's a common not an uncommon thing.
It's a rejection factor. It's a rejection factor.
Totally informed consent. Yeah, that's because they feel overwhelmed.
Consent at every step is very necessary.
Yes, everything is very necessary.
Yeah.
So you can say that 50%. You can say that 50% of our time is going to go into data logging and documentation from now on. That is more important now. And I'll request you that we move.
There was this one more thing that I just wanted to add. What are the most important things apart from the KPIs, for quality? So there's one thing called disaster management or risk management.
Yes.
you need to have the right processes if disaster strikes. Like if you have critical situations happening in the laboratory, cryo failures or incubator failures, you need to have a plan of action.
Yes.
You need to
Finally, we'll
have-
come to that. I think we will move to the next. We
Oh.
are slightly short of time, so let's move ahead.
That's right. Please go ahead.
Yeah. Yeah. Okay, Akash, yours.
Yeah. I mean, we have got quite a few points in this in terms of lab in charge.
Yeah.
But quickly, anything extra other than what we have discussed, other than your quality KPIs and when you see it in terms of other than the patient side, is it something else you need to consider?
Somebody who can really manage the juniors.
Yeah,
That's a very
Somebody who has a
leadership.
good amount of patience.
Authority
Yeah,
and
he should have
leadership.
good leadership quality.
No, but let me put
Leadership.
it. Today's juniors are much
Because
more.
they're right. Yeah, Doctor.
Today's juniors are much more intellectual, smarter, and they have got that zeal to learn much faster. Sorry to say, what we had 15 to 20 years back.
Right.
Because we had small amount of work, but we had qualitative work. Now the work is distributed amongst, I think by that time we finished this lecture, that I'm sure in India, one IVF lab must have inaugurated. Okay. So such fast is the springing of labs all across. So definitely the patients get diluted. Along with it, the cost-effective competition comes in. So when the price-related competition comes in, you know what happens. I should not spill the beans over. So the thing is, the juniors as well as the seniors in the laboratory should be learning how to accept failure as a part of success, because it is not entirely their fault. Many a times we expect too much. As I very rightly said, whenever there is a failure, go all the way back, pinpoint the cause. If the cause is yours, gleefully accept it, rectify it, and make it a point that it should not repeat again. This will happen only if there is a homogeneity in the lab. There should not be an element of suspicion amongst two people. The gynaec shouldn't say, oh, he has not scanned the eggs properly, I'm sure he has missed the eggs. You know, some sort of that discordant band should not set in, because all this sets negative vibes, and this will clash up the trust between the two.
It's not very true that it's not only about success, but also not only the positive sides, but the negative sides which you have to see for. I mean, we have one question for that. Like, it's not just the positives.
No,
yes,
what I'm saying is, even if there is failure, this is the positive side of failure.
Yes,
Because
you can consider it as a stepping stone to success, like we would say.
Right. Yeah. Just to clarify, what I mean by managing the juniors is basically to have all parts of communication open with them. And the whole team, because there are so many ways miscommunication can happen in the smallest things like this preparation, or what media they need to incubate and what kind of dish they need to make. First of all, you need to have your SOPs so that they can follow them in case they can't reach you. But in general, when you're running a lab with multiple cases and you have juniors on the team, you need to be open and transparent with them in terms of what are their responsibilities, what are their deliverables, and what they need to bring to the table, and as well as take the responsibility of their failures sometimes if required, because if you are the in charge, you are responsible for many of their failures, especially if you have not made the right processes and not given the right training on time.
Because the juniors today are literally spoon-fed. Here we had worked with our backs on the chemical balances, weighing the media contents, molecule water, autoclaving. Now today, just rip and start utilizing it. Finito, that's it. The times were different, but still we used to enjoy the work. The work satisfaction was there because a healthy environment was there.
Even actually lab in charge also can learn from the juniors also. It is not like that always that lab in charge is.
Yes, very true. Yeah. Everybody has his or her own learning curve and a learning phase.
It's a two-way process. Learning is a two-way process.
The word peace of mind is equally important.
Yeah, in embryology, actually, nobody can be a master at a time. You are continuously learning and learning.
Nobody can say I am the master, because we all know what results are portrayed and what actually happens. Let's be very practical about it.
No, exactly. And every day you are getting patient, you are having new experience.
Yes, every patient, sir. Every patient is new. Every semen of the same patient is new. every 2 sperm of the same patient from the same ejaculate is new. Something of that sort.
Fully agree. Fully agree.
From the clinical side, what I would say is, as a lab director, we are speaking only to the lab director. We don't speak to anyone else. So that he is the person whom we communicate everything with. So I would want a lab director who is actually aware of the entire clinical protocols also, because that helps in nice decision making, and and he should also think of the growth of the organization, where the path to take the organization. So many other critical things come other than the KPI quality control.
So wherever there is a large network, a whole teamwork, you should have regular meetings. You should have case discussions. What is wrong? And please listen to the justification of the most junior. Now, many a times they are neglected. So obviously they get a sense of dissatisfaction, because everybody's grievances, listen together, pool together, who might know that he might come up with something fantastic like a new suggestion. Everything can be implemented, provided the team works as a team. It's like that.
Agreed.
Yeah, and the communication between clinician and embryologist is very much necessary.
Fine,
Yes,
fine,
agreed.
fine.
So let us move to the next question. We are very short of time now. Yeah. So what is your definition of a good quality embryo or a good embryologist? You as a teacher, would you consider the most important quality for an embryologist, the one that can be inculcated and the ones which can be learned? Okay, I'll start with Pranay this time.
I think I'm sitting at a place where I can safely say that the person needs to be loyal and the person should be willing to learn. Rest, everything I'll take care of. Rest, everything can be taught.
Very important.
Don't bother about the KPIs, don't bother about degeneration rates and cryo survivals. But just the person should be willing to learn and be loyal. That's it. That's the only 2 parameters that I look at.
Great. Can we have 1 point from everybody? Dr. Hegde, please, can you give me a point here?
I would want to trust them totally. That's it. Where I don't need to look back again into embryology lab. I take care of the clinical side and they just take care. So trust is very important.
Loyalty and trust, I think.
Trust and loyalty.
Literally understand us. I mean, they should be able to take decisions without my telling. That's very important.
I would put it, the embryologist should consider his lab as his second home.
Yes, well said.
Very true. Maybe the first home instead.
First home, sir.
Actually,
First home. That's the first home.
Many a times we realize that how much care, how much meticulousness we used to take in the lab. Of course, our home we used to be pristine and clear cut as such, but still there were certain parameters where we used to exceed the sense of cleanliness in the lab.
Yeah, and one more, actually, embryologist should be dedicated. Embryologist should be dedicated to work, and he should work on the timing of the gametes, not according to timing from 9 to 5 work.
Just before I forget, I want to add, we as clinicians, we are dependent on embryologists for witnessing. So witnessing is very important, and that is something that the lab director has to ensure. So when we talk about selecting an embryologist, we are leaving that parameter to them totally.
It should be non-partial, non-biased witnessing. Now, suppose I have a witnessing person who is a little taggy with me, friendly. If a little grade here and there, let go. So that's why it is always non-biased witnessing, just like a counselor. An individual first counselor has to be not restricted to your laboratory or hospital. He should be an independent counselor, not having any special affiliation to your lab or the concern. So he is not bound to give a biased counseling advice. Similarly, witnessing is very important, and they should be generally justifiable, howsoever close he or she may be to the embryologist concerned. All later on, once the procedure is over, you may find them in a hotel having a cup of tea together. We can't say that.
All right.
So transparency is the word.
Yeah.
And with witnessing, I think we'll move to the next question. Witnessing is one area where we find it to have a zero error of acceptance. That's one area with double witnessing with respect to gametes. And we can go on about, sigma 6 level errors of error control. So errors, nobody wants to have them, but they'll creep in. They could be avoidable or unavoidable errors. So what would be the plan to minimize them, and how would SOP play a role in that? Anyone can take. Yeah, sure, carry on.
Who's carrying on?
Who are you asking? So should we?
You can see errors will creep in. howsoever we are professionally organized, certain inadvertent overlooked errors may creep in. Certain things which we've not even expected suddenly can creep in. So it is not possible for us to humanly avoid everything. But we have to try our level best to see that those are minimized as much as possible and that occurrence is not repeated over time and time. Ample resurrection has to be done on the error which we observed or witnessed in a certain patient's procedure.
Okay.
Right? And you should not give it a chance or a benefit of doubt that second time it will not happen. Don't worry, it was that unfortunate incident which happened today. Whatever be it, please rectify it immediately. Because sometimes it works for us, many a times it works against us. And the sad part is the only suffering person is the patient, not us.
Agreed.
Right.
Agreed.
So errors are avoidable and unavoidable, and quality is in not only in terms of giving good success, but even avoiding errors, and most importantly, learning from them and not repeating them.
Yeah.
An error must be reported on time.
And that's where transparency comes in. Absolutely.
And bringing the error into notice of the person in charge, that's very important. Just, I mean, juniors should be taught this, that report immediately if you've committed an error.
It should be a root cause analysis where we see not who has done the error or why it has happened.
Right.
Sure.
So could I add a quick case study of what we have faced in one laboratory in terms of managing errors or managing. So when we had learned Six Sigma, it's not easy to really go as a technical person and implement these practices directly in a laboratory. So if, for example, most of the people in the audience and in the panel know what ISO is, and in small basic terms of what TQM is. But then when you're actually trying to implement it to reduce errors, if most laboratories, IVF laboratories now have NABH accreditation, or and they have a different module for IVF. What they have is they have an incident reporting. They want you to create an Excel sheet to have incident reporting. In fact, they want you to create an Excel sheet for all the procedures that you do on a certain day in the laboratory, only in the IVF laboratory, and a different one for the operation theater. So what we did in one laboratory is we said, okay, you're already managing this Excel sheet. You're already entering how many semen preps you did, how many pickups you did, how many ETs you did. They had 2 people only just doing the data entry who were part of the laboratory. I said, just add an incident reporting column and use it to monitor your internal incidents, and take all those incidents, put them in a meeting, report them during a meeting to the clinician, mark them as critical, moderate and low, and start putting the critical ones immediately to the notice of the lab director, immediately to the notice of the person, the clinical medical director, and the moderate ones can come up in the weekly meeting, and the low ones can come up in the monthly meeting. So this was something that we did, and we really did see a difference in how many errors the lab actually started reporting. They started actually reporting more errors because they saw that it was a transparent atmosphere and they were allowed to write all the incidents that happened in the lab. So this is something I think where the culture of the lab comes in picture. That errors are unavoidable, but reporting and seeing them, reporting them, it's really dependent on the lab of the culture. We need to create a culture in the lab of reporting, seeing all the errors, creating an incident reporting format. Just creating a format and putting it in the lab is useless if you are going to have a blame game going on. So this was something that you saw in a lab, a very positive change, and I just felt it could help other labs in the process.
I'll just interrupt. Dr. Pranay, are you with me?
Yep.
Yeah. See, I just want to tell you or suggest is that when we attain the Sigma 6 level of clean SOPs, etc., some people are of the opinion that they will be practical only if we are a very high-tech, professionally built lab with flush of money into it. It is not so. Certain simple basic occupations have also achieved the Sigma 6 level. Now let's take an example. In Mumbai, you must have seen the dabbawalas bringing the tiffins of Lakhs of people from various houses all over the suburbs come rain, wind, snow, whatever it is, properly at the right time. And till today, the chance of two tiffins getting mixed is as good as negligible. Now they don't have any system, they don't have any QA/QC SOP, but it is simple system of marking the boxes and their dedication towards it. That is the thing. Otherwise, you have tons of formats, you have tons of guidelines.
You can say
have
that it
tons
is the
of-
SOP that is important here.
Yes, the SOP which is over here.
Yeah.
The gray matter which exists between the 2 ears is important, and the dedication from the heart should come. Now, this will come in the junior embryologists provided, sorry to say, they are remunerated well. What is the biggest sense of dissatisfaction amongst the juniors? Not given things to be done, not given proper remuneration, thereby leading to job dissatisfaction, ultimately jumping jacks today in this lab, tomorrow in that lab. It's like that.
Not getting adequate.
That is the harsh reality. Agree.
Yes, that is the harsh reality. It exists everywhere. And sorry to say, in spite of so many guidelines, associations, bodies, I would think things are taking 2 steps back rather than 1 step forward. That's my opinion.
All right. I think it's a very big discussion, but I think we should move to the next question now. Yeah. So, Akash, you want to take this?
Yeah, you please go ahead.
Okay. So ultimate success for patients, delivery of healthy baby. Sometimes that is not possible. What do you do in such situations? Let me start with Paresh this time. And then we can have Dr. Hegde. Paresh, are you there? Is Paresh there?
Yeah. Sorry. Yeah. Sometimes the delivery of the healthy baby is not possible. Actually, at that time, I believe that the counseling part came actually. And you have to take care of the counseling, because what happened when patient came positive, they are everybody ready to counsel the patient. Okay. But when patient is negative, you have to take the responsibility, because actually, though we have a lab stress that patient got negative, but patient is very much stressed. So I personally believe here that there should be a strong counseling for that patient.
Right. Dr. Hegde, would you like to add anything to this?
When a patient comes with failure, what I would say is, see, there's always a saying, that never change a winning team. But in IVF, per se, what I would always say is, don't immediately change a losing team, because we have to explain the patient why it failed. So what we have to explain the patient is, we did everything the best way possible. So none of our things, there's no mistake from our end. Because patients is always suspicious, did everything go right? Once you finish this part of the counseling, then we need to sit with the patient and discuss what will be the evaluation for her, why the failure happened, at what level, was it a gamete issue, implantation issue, or was there some other factor that is involved, and then bring about a change. See, patient always expects that the next cycle is going to be changed with respect to our stimulation, with respect to our embryology lab parameters. So it is important for us to counsel that not everything needs to be changed every time. Sometimes when you repeat the same scenario again, there is a chance for pregnancy, because IVF conception rate is you have to always keep telling about their success rates. So what I would say, counseling is very important to decide the next protocol for them. So whenever we evaluate, we'll be evaluating with respect to so many scenarios nowadays, whether it's receptivity, does it require any testing, whether any genetic evaluation of the embryos have to be done. So all these are again recommended only after 2 failures. So this concept has to be taught to them. 2 IVF failures is a norm. It is not something abnormal.
See, many a times it does happen that, the donor conditioning is done, the patient are already counseled for donor even in the first cycle. That does happen. So do you think it's the right way or not? Yeah.
No,
that's an easy way out, I would rather say here, because in India, it's very easy to convince a patient for donor as compared to other countries.
So what I tell patients is, IVF is not like appendix problem. You just come, you know what the diagnosis, you just remove it. But with IVF, I cannot tell there's always a black area or a white area. It's always a gray area we are running on. It's so difficult for the clinician to take decisions. But at the end of the day, we are actually have to give the genetic link to the baby. No, it is not so easy to connect. Today, I think all the patients want their self gametes. I see patients struggling through almost 3, 4, even 6 IVFs to have their own child. So I see that kind of motivation in patients nowadays. So I think it's a very good, I think going forward, we are going to see a lot of patients fighting for their self-gametes. No, the donor oocytes and donor gametes are decreasing now.
All right. Okay. Anybody would like to add anything to this?
Yeah, I understand the wording of the question a little differently. You say that the delivery of a healthy baby, sometimes that is not possible. So probably what I got from the literal gist of this statement is that you are dealing with an unhealthy baby. So in my experience, babies don't have a high degree of or high proportion of major or minor congenital anomalies. What you have to be mindful is
sorry to interrupt, Dr. Akash and Nishad, we're running out of time.
Yeah, sure.
Okay, so
we'll
this is
just
the last
finish
question.
with this question. Absolutely, no problem. Sure. Yeah.
So what you can do is, as a embryologist and as a clinician, is avoid iatrogenic things like doing a double embryo transfer, having a twin delivered or a triplet delivered preterm, which is struggling with retinopathy of immaturity or other stuff like hypoplastic, the ARDS. So in my opinion, if you have done adequate with self gametes and you have done an elective single embryo transfer, and if you have screened the pregnancy with the dual markers and the triple and the quadruple markers and NT scans, I think that over and above, you cannot do anything more than that, because you're working with self gametes, and this is what was destined to happen. Of course, we have talked about counseling, which needs to be done at every point of.
Right. Right. So the key message with this is actually very good counseling and make the patient comfortable with whatever the outcome is, so that they still, have that hope that maybe this failed, maybe in the next cycle they will be having a healthy baby in that case. All right. So,
right.
I think
we
this,
can sum up this webinar, since I think we are running out of time.
Right. So I think we'll end this and please go ahead, Akash.
Yeah, it was lovely having all the panelists and the different view over this. And quality is not about just numbers. It starts right from when the patient walks in, as has been highlighted in this webinar, that counseling is where the quality starts in. What kind of treatment you decide, making them have an informed decision. That is a very important part of quality. And post that comes your treatment, which is there, and then comes your lab KPIs. And it is not only the patient, but even the other personnel in the lab, the communications, which is important as part of quality, minimize the errors. And obviously you have to take care of your staff as well, which would be very, very crucial. So that's it from my end, I would say. Nishad, if you'd like to anything.
Right. I'll thank all my panelists. You've been wonderful, and really happy to have such a wonderful panel with such a wonderful outlook. Thank you very much. And I thank iHera for a wonderful embART 2, and all the best to everybody.
And really, I would like to thank my co-moderator as well.
And,
I would
Sanket and Paresh and Rahul. You guys are doing a great job, and definitely weights are no doubt.
Thank you, Nishad. And
thank you. Yeah, thank you so much.
Obviously. Yeah.
Thank you, everybody.
Okay, over to the coordinators.
Yoshita, you can take over. I think there is a network problem there.
Okay, let's move on.
Please check Dr. Joe is here.
Dr. Joe, are you there?